Welcome to 5-Minute Journal Club, the current and future role of tumor-informed ctDNA assays across oncology. Today, part 2 of our series on urothelial bladder cancer with Professor Thomas Powles from the Barts Cancer Institute, Queen Mary University of London in London, United Kingdom. This is medical oncologist Dr. Neil Love. And to begin the next part of this conversation, Professor Powles commented on ctDNA findings of the landmark Phase 3 Checkmate 274 trial evaluating adjuvant immunotherapy.
Checkmate 274 is an adjuvant trial with nivolumab. It has set a standard of care in this environment that probably now has been superseded by neoadjuvant EV Pembro. In that trial, the study showed a DFS advantage, so it delayed the time for the cancer to return, but it never showed a significant overall survival advantage. We in bladder cancer feel overall survival is a really important goal to achieve. The folks from this study did circulating tumor DNA analysis, and they showed very similar results to IMvigor010. Essentially, what they showed is at baseline, it was strongly prognostic. So the chance of the cancer coming back, if you were ctDNA positive, was nearly 100%, whereas if you were negative, it was a much lower risk at about 30%. And they also showed in subsequent analysis that the benefit associated with nivolumab in terms of hazard ratios was confined to the positive population. So the negative population not only were at lower risk, but the hazard ratios were about 1 associated with nivolumab. This is very much aligned with what we saw with IMvigor010 and IMvigor011. And together, this produces a landscape of data demonstrating clearly to us there's a group at lower risk, number 1. Those patients can potentially be spared life-changing toxicity associated with the drug. The drug in unselected patients never achieves survival, but in those positive patients, we do get survival. So inevitably, in those negative patients, the results are not significant.
So I guess this is like Journal Club 2026, because the next journal paper actually is 4 papers that all sort of in one way or the other deal with a similar concept. And I'm just kind of curious globally in terms of how you see this. When you were talking before about neoadjuvant therapy and what happens if they clear their ctDNA, I was kind of flashing a little bit. I know I have these weird things that come up in my mind because we're in all parts of oncology, but believe it or not, to the use of neoadjuvant IO in MSI-high localized rectal cancer, where, of course, there was this famous, New York Times study from Memorial where they showed these people all had CRs, and they're not doing surgery on these people now. So, of course, that leads to the question, you have to have good drugs also, as well as a good biomarker, but can we avoid cystectomy? And I guess a lot of these next papers are really tied into that concept. Can you comment a little bit on what they report, what they're looking at, and where you see things heading in that regard?
So bladder cancer is changing very, very quickly, and keeping up with that change is challenging. It will stop changing in the next 3 or 4 years. As always, there'll be a seismic change, and then there'll be a period when we have to react to that. But at the moment, I think we're 3/4 of the way through that. The change that you refer to is, do we need to be doing surgery in unselected patients? And is upfront surgery the right approach? At the moment, I tell my patients the most important thing is a good operation. Neoadjuvant chemotherapy is the icing on the cake. I think that's going to change around completely. I think we're going to come into an EV Pembro first, ask questions later environment in the near future. EV Pembro is associated with a pathological complete response rate of 55% in 2 randomized trials. That essentially means the majority of patients who are having an operation have no cancer left behind. Those patients inevitably are disappointed that they've had a potentially unnecessary operation. Those patients in the future will be asking for MRI scans and cystoscopies and circulating tumor DNA analysis to identify whether or not they are at risk of their cancer coming back. And I suspect those patients who are not at risk, who have a negative MRI, a negative cystoscopy, and a CTA negative, will say, you know what, I'll keep hold of my bladder and I'll trust my luck. Thank you very much. I potentially support that approach, although we need to generate robust data to show that that is safe. We don't have that data yet. What you describe in some of the trials in front of you, which do not address this question specifically with EV Pembro, but with chemotherapy and with immune therapy in the RETAIN trial, in Matgowski's trial, but there were other radiotherapy trials as well, trimodality radiotherapy trials. What all three of these trials tell us is actually kind of what we know already, which is being ctDNA is strongly prognostic at each time point if you're positive. If you're negative or you've cleared your ctDNA, your outcome is good. And this is important, both through radiotherapy and with bladder sparing approaches, if you are ctDNA negative and your bladder is still intact, you are at lower risk. And so this is beginning to move into that new chapter where ctDNA tracking will be used to make sure or to define whether or not patients should have surgery. And this is not finished yet by any stretch of the imagination, but these 4 publications enter into that new concept of, can ctDNA help us in bladder sparing approaches?
So I was mentioning that those videos you did with cases that we showed at ASCO GU were so well received, but we also had some cases and videos by Betsy Plimick. And one of the cases she presented was an 80-year-old man, actually platinum eligible and good condition, who she was putting, I guess she has a one-arm study looking at EV Pembro and then following the patient if they're ctDNA positive. Do you think that that's where we're going to be in a couple of years?
Well, Betsy's group has done some terrific work. Of course, they led the RETAIN-1 and the RETAIN-2 trial, chemotherapy plus nivolumab. And in that study, patients essentially who were in complete response were able to go on and not have a surgery and not have radiation therapy and be tracked. What she showed in her trial, I think, were 2 really interesting issues. The first is, if you remain CTA negative, your chances of dying of bladder cancer is really small. And number 2 is that if you have a local relapse in your bladder, you do not necessarily become ctDNA positive. And that makes sense, because if you have a T1 cancer, that may not actually be associated with blood-related ctDNA. Clearly T2, 50% positive, T1, probably only 10 or 15% positive, T3, 60, 70% positive. So therefore, we do need to be observing what's going on in the bladder, either with cystoscopy or indeed in the future with utDNA. The question you've asked is whether you think EVP will supersede all of this. And the answer is yes, I believe it will. I think the work we're doing at the moment with chemotherapies, because we've had chemotherapy for a long period of time, we're doing all of our homework, all the background work with utDNA and ctDNA with chemotherapy currently, because that's what we've been doing for the last 10 or 20 years. But these 2 new neoadjuvant positive EV Pembro trials will mean that all of the work will now shift gears to EV Pembro. The results are going to be better. Number 1, path-CR rates with gem-cis durvalumab, 37%, path-CR rates with EV Pembro, 55%. So the results are going to get better, and therefore we're going to be using EV Pembro preferentially, but we will also be using ctDNA because we know EV Pembro does not cure everybody.
In terms of neoadjuvant EV Pembro, do we have any data on ctDNA based on path-CR or not, or particularly in the path-CR patients?
In EV Pembro, we don't currently have that data, but we do have data from Niagara with path-CR. Right. And if you are ctDNA positive, you almost certainly, 97% of those patients did not have a path-CR. But if you are ctDNA negative, 50% have path-CR and 50% do not have PathCR. So it's pretty hopeless, actually, in determining PathCR. And that then related to Betsy Plimak's data, which showed that she was unable to identify local relapse associated with ctDNA. What is true, Neil, is when we do these results, we are getting exceptionally consistent results with ctDNA. We're yet to have a data set come out using an informed approach, which turns everything upside down and makes it confusing. And that's why I think this will stand the test of time. It's why I think Modern's an important trial, because I suspect it will show exactly the same again. And this consistent signaling is going to be very reassuring for clinicians and patients.
So I'm curious about your thoughts about this. Looks like it's called the CT Read study, looking at ctDNA and metastatic urothelial carcinoma. Again, across oncology, we're seeing a lot of patients with metastatic solid tumors, including urothelial, GI, breast, people using it in the metastatic setting. Can you talk a little bit about this study that's going to try to further define where that is and where it's heading?
A Read trial, I think, has a role to play, and I think it's an exciting study. It's a dose de-escalation study of enfortumab vedotin and pembrolizumab. In metastatic disease, we have both ctDNA analysis using panel-based approaches and informed approaches. Here, where the accuracy perhaps is less important, because almost all patients will be ctDNA positive because they have advanced disease already, both of those techniques have a role to play. In this Read trial, they're asking an important question, which is if you get clearance or you get big reductions in ctDNA levels, do you need to keep going with the EV pembro? The enfortumab vedotin is associated with adverse events. The moment we keep going indefinitely, potentially, although my feeling is somewhere between 1 and 2 years is right. I think more than 2 years is complicated, but many patients want to keep going for more than that, in my experience. This question, this study answers a really important question. If you clear your ctDNA, do you need to keep going with the EV? I think it's a great trial. I like the idea. My gut feeling on this is I don't know what the trial results are going to show. It's one of those areas which could go either way, making it, in my opinion, a really important question.
Seems like there are a lot of situations now where people are having toxicity, particularly peripheral neuropathy. They may start out with peripheral neuropathy even before they're treated, where they, really want to minimize therapy, that this could be a consideration. Right now, are there situations, are you having a patient who's having a lot of issues, who has a CR? Would it be helpful, do you think?
Neil, I'm just going to talk, if I may, about duration of enfortumab vedotin and whether ctDNA and radiology help us determine that duration. We've made enormous progress in urothelial cancer. We've gone from similar outcomes to pancreas cancer, speaking frankly, and we've shifted that goalpost, curing 30% of patients with metastatic disease, PathCR rates at 55 to 60%. And that transformation has been by giving longer periods of EV. And that is until progression in the metastatic setting and 9 cycles in the perioperative setting. I am quite anxious, having made all this progress, that in clinical practice, we're now saying, well, do we need to give it all? Maybe I can give 2 or 3 cycles here or there and hope for the best. I think these are legitimate research questions, but at the moment, I feel we should stick as close to the study protocol design that got these incredible outcomes as we can. So what role does radiological complete response in advanced disease or ctDNA clearance in muscle-invasive bladder cancer have in early cessation of therapy? Outside of a clinical trial, I would say that's experimental in both of those environments. In metastatic disease, I would, for those patients who are not getting toxicity, I'd be tempted to go on longer rather than shorter, because that's how we achieve those 40% 5-year survival rates, number one. And then number two, in perioperative disease, I would be aiming for 9 cycles of therapy until proven otherwise. And let's do those studies and find out where we are. The other question I'm asked a lot is, do we give 3 or 4 neoadjuvant cycles? One trial gave 3, the other trial gave 4 cycles. Why did that happen? I can tell you why we picked 4 cycles in one study. That was because 4 cycles of chemotherapy was the standard of care. We wanted to get like for like. In the other trial, we felt, well, let's do the surgery at an optimal time, and we felt going on with EV Pembro for too long might be risky. It wasn't based off science for cisplatin eligible or ineligible patients. It's pragmatic. In the perioperative approach, I would encourage people to say, we aim to give 9 cycles of EV Pembro. We aim to go for a year of pembrolizumab. An operation should take part somewhere in the middle. In most of our centres, we don't have control over the exact date of the surgery. And actually, it doesn't matter if it's after 3 or 4 cycles. What we know is if you do that, and then in those patients that can restart, you restart. We know those patients have about an 80% relapse-free survival rate at 2 years. Really encouraging. So overall, let's try and stick to what we know. Let's do studies like this dose de-escalation study in advanced disease. There's a study called Volga, which only looks at 3 cycles rather than 9 in the perioperative. Let's look at the results of that trial. But in the short term, my preference is to stick close to what we know because the results have been so exceptional.
One thing that comes up a lot in other tumors, particularly colon cancer with isolated liver mets, is oligometastatic disease. How often do you see that in bladder cancer? And do you think that, a sort of InVigor type approach or, pseudo-adjuvant type approach to that, if you have, let's say, isolated met or oligomet removed or locally treated, do you think that's relevant there?
So I think what we know from the ctDNA analysis is that urothelial cancer is a systemic disease, much more so than prostate or kidney cancer. If you have one node that's positive, the likelihood is there will be dozens that are positive. And chasing isolated metastatic disease with surgery or even radiotherapy without knowing the history of the rate of the growth of that cancer, in my opinion, is risky. So oligometastatic disease requires systemic therapy, even more so than ctDNA positive disease. And so I would not be advocating the use of radiation therapy or surgery under these settings. If you had oligometastatic disease, I would giving EV Pembro. Now, if you give EV Pembro and after 2 years you have one isolated lymph node that appears, then should that be targeted with radiotherapy? I think that's an entirely reasonable approach. But I think we need to move away, in my opinion, with such effective systemic therapy. We should be moving away from, targeted oligometastatic treatment. After all, this is a systemic disease, much more so than prostate and kidney cancer.
So final paper or 2 papers, the first time I heard about urinary tumor ctDNA was the last time I talked to you. And I was like, wow, that is really interesting. And of course, first thing I thought about was non-muscle invasive disease and whether you even see it in the urine. Here are a couple trials in progress. They're going to try to look in this general issue. Do you want to comment about urinary ctDNA, particularly in the non-muscle invasive situation?
So I love the endeavor and the ambition of UTDNA. It does feel very similar to our place with ctDNA 5 or 6 years ago. There is a real clear need, and we demonstrated this in the non-muscle invasive bladder cancer immune checkpoint inhibitor studies. We did CREST, we did POTOMAC, and we did ALBAN. In these trials, we showed immune checkpoint inhibition probably was effective in some patients, but we're probably over-treating 70 or 80% of patients. Wouldn't it be great if we'd identify those patients clearly at risk? Baseline T stage, presence or absence of CIS, none of these parameters really are identifying this risk group in enough detail. And so therefore, ctDNA would be potentially attractive. But as I said before, from the RETAIN trial, we've identified that ctDNA is not great at identifying non-muscle invasive bladder cancer, but utDNA probably will be. And that, I think, is where the utDNA story ends, where it is good at identifying local relapse. I think we'll be able to identify local risk. And I think the ctD or the utDNA levels, the MTM levels or the VAF levels, will give you an indicator of how big the risk is. And that may identify subgroups of patients who need early or more aggressive treatments. So I am a huge fan of utDNA. I think it's an expanding field. I think we need a little bit more work on accuracy. It appears true that the bladder urothelium can, as time goes by, develop its own group of mutations resulting in false positivity, but we need to explore that in more detail. So there's still some work to do in this space. But these sorts of trials, particularly looking at utDNA in those individuals at risk of relapse in non-muscle invasive bladder cancer, I think more so than ctDNA will stand the test of time.
Yeah, I mean, when you think about the public health implications and the number of people out there who are having procedures and all kinds of other interventions, that theoretically this could have a gigantic impact.
Potentially, we have to show it's more accurate than urine cytology. We have that there at the moment. Let's not overcomplicate things for the sake of it. But urine cytology is not telling us enough about risk. There would have to be something here on top of what we know, because just adopting things that add little value, I'm not a fan of that. Let's not overcomplicate it. But I think utDNA has a chance of identification, not only of those patients in bladder-sparing environments where relapse occurs, utility there, but I think it also potentially increased risk in non-muscle invasive bladder cancer in those patients at risk, early intervention. So I'm excited by this, but it has to add something.
This concludes our program, and please note the attached slide set providing more information on the papers and presentations discussed here. Special thanks to Professor Powles, and thank you for tuning in. This is Dr. Neil Love for 5-Minute Journal Club, the current and future role of tumor-informed ctDNA assays across oncology, urothelial bladder edition.